The following podcast is part of a certified educational activity titled Changing Perspectives on Multiple Myeloma and ASCT, Clinical Decision-Making, New Evidence, and Expanding Therapeutic Options. Access the entire activity and complete the post-test at peerview.com/JHF860. Downloadable slides and practice aids are also available.
Thank you all very much for joining us during this lunch session at TCT. I'm joined by my colleague, Dr. Philippe Moreau, and together we're, in the next hour, going to review changing perspectives on multiple myeloma and transplant, and really talk a lot about decision-making, evidence, and expanding therapeutic options. And one of the things that I think is very challenging in managing myeloma patients is that the field is moving so rapidly that decisions that you made a year ago may be different today. And so I think knowing and having access to all that information is really quite important. So I'm Sagar Lonial, and I'm going to talk a little bit on the relapse setting, and my colleague is going to talk about induction therapy and maintenance. Okay, so I think looking forward, it is important for us to think about what's next in transplant-eligible patients. We know that from 2012 to 2019, we've had the approval of next-generation PI, IMiDs, carfilzomib, ixazomib, pomalidomide, CD38 and SLAMF7 antibodies, HDAC inhibitors, XPO1 inhibitors, and MRD assessment added to NCCN guidelines. And beyond 2020, we know we've got new immunotherapy approaches, other novel targeted approaches that I'm going to touch on a little bit. And so I think the landscape in myeloma, as I said earlier, is very rapidly changing. So I think it's important for us to think about how we do this. So I'm going to turn over part one to my colleague, Dr. Philippe Moreau, who has many different titles. I just call him the king of myeloma in France. And Dr. Moreau will talk to us about novel induction platforms, maintenance, and MRD. Philippe?
So I would like to share with you some data regarding the frontline treatment with stem cell transplantation. And we are proposing systematically in Europe high-dose and stem cell transplantation as frontline treatment up to the age of 70. But is it evidence-based, in fact? This is the IFM study reported in the New England in 2017. This is one of the studies supporting strongly the use of frontline stem cell transplantation. Patients were randomized to receive VRD without stem cell transplantation or VRD plus frontline stem cell transplantation. 700 patients were randomized, and you know that the progression-free survival was highly improved in patients receiving stem cell transplantation frontline versus VRD alone, in fact. So a strong PFS benefit with frontline stem cell transplantation. And when you are looking at MRD negativity rate, in fact, in the transplant group, 80% of the patients were able to reach MRD negativity, 10 to the minus 4 by flow, versus 65%. So a higher rate of MRD negativity with stem cell transplantation. And when you're looking at those patients reaching MRD negativity in blue, you can see that overall survival was also improved for patients reaching MRD negativity. So that's why in the routine practice we are always proposing stem cell transplantation frontline. This is also true in the US for many centers. The recent NCCN guidelines updated last October are proposing stem cell transplantation as the first option, and the preferred induction regimen into these guidelines are either VRD or VCD with cyclophosphamide added to bortezomib and dex. Here, the European guidelines published in 2017, and we are also proposing either VRD or VCD, but also a third option that is VTD with thalidomide, that is the most preferred regimen in France, Italy, Spain, for example. The PAD regimen is also proposed, but almost never used in the routine practice. So why are we proposing VTD instead of VCD in some countries? you know that there is a synergistic activity when we are combining a proteasome inhibitor, bortezomib, and an IMiD thalidomide, and we did compare prospectively VTD versus VCD, and we showed that after 4 cycles and before stem cell transplantation, there was a higher rate of response with VTD versus VCD. You can see the PR rate was improved, the VGPR rate was also improved. But the toxicity is totally different when looking at VCD, that is a very convenient regimen, very active as well. We have a higher rate of peripheral neuropathy for sure when combining thalidomide and bortezomib as compared with cyclophosphamide and bortezomib. So why we don't have any prospective comparison of VTD versus VRD? And it's quite logical to switch from thalidomide to lenalidomide. The Spanish group published consecutively 2 important papers, one with 6 cycles of VTD induction before stem cell transplantation, and another paper more recently with 6 cycles of VRD followed by stem cell transplantation. And they reported this very important integrated analysis of response for patients treated either with VRD or VTD. And you see that the response rate is higher with VRD. After 6 cycles, 66% of VGPR or better as compared with 50% with VTD alone. And this translated into a better progression-free survival. This is not a head-to-head comparison, not a prospective study, but nevertheless, we have 2 consecutive trials showing that potentially VRD is the best option. So that's why now in many countries in Europe and in your country, in a routine practice, VRD is a preferred regimen before stem cell transplantation. When looking at another guidelines proposed by the Mayo group, the MSPART algorithm, you see that for patients with a standard risk, in fact, after 4 cycles of VRD, stem cell transplantation is the preferred option, but in some cases, you can also propose VRD without stem cell transplantation upfront. And again, the issue of frontline or delayed stem cell transplantation is an important one that is commonly raised in your country. On the opposite, when patients at a high risk, the Mayo group is proposing either KRD or VRD plus daratumumab before stem cell transplantation, and we are going to discuss about these other combinations, KRD or a triplet plus a CD38 antibody. So how to improve on VRD, for example? We can use carfilzomib instead of bortezomib. And this picture is showing the results of KRD followed by stem cell transplantation in yellow as compared with KRD without stem cell transplantation. 2 consecutive phase 2 trials from the group of Dr. Jakubowiak in Chicago. And definitely you see these very good progression-free survival, outstanding results, in fact, with KRD and stem cell transplantation. And KRD was prospectively compared with Carfil Cyclodex, KCD, in this study coming from Italy, the Forte study, KRD and stem cell transplantation and KCD plus stem cell transplantation versus KRD without stem cell transplantation. And when you're looking at the results of induction, 4 cycles, in fact, 4 cycles of KRD, you have a VGPR rate of 73%, so a very high VGPR rate. Think that with 6 cycles of VRD, as I mentioned previously, 6 cycles VRD, 66% of VGPR, and here we have 4 cycles of KRD and 73% of VGPR. So definitely, we don't have yet any head-to-head comparison of KRD versus VRD, but nevertheless, we can anticipate that KRD is a better regimen in terms of response. The other possibility is to add a CD38 antibody to a triplet, and we did this prospective trial looking at VTD versus VTD plus daratumumab, both before stem cell transplantation during induction and after stem cell transplantation during the consolidation phase, Cassiope randomized more than 1,000 patients in Europe, and we looked at the response rate, and this response rate is improving over time after induction, after stem cell transplantation, after consolidation, and the rates of response is much higher in the arm with daratumumab as compared with VTD alone. This translated into a better minimal residual disease negativity rate after consolidation and before maintenance, assessed by flow cytometry systematically for all patients at 10 to the minus 5. And in the DARA arm of the study, 64% of the patients were able to reach MRD negativity before maintenance, as compared with 44% only in the VTD arm of the study. So a higher rate of MRD negativity with a quadruplet combination, and this translated into a better progression-free survival. You see here the DVTD arm and stem cell transplantation versus VTD and stem cell transplantation. The hazard ratio is less than 0.5, and definitely very good results at 18 months or 2 years in the DARA arm of the study. The follow-up is rather short, but nevertheless, there is already a trend for a better overall survival in the DARA arm of the study. The median OS obviously is not reached, and we have to look at the overall survival after a longer follow-up, but look at the outstanding 2-year overall survival rate, 97% on an intent to treat basis in the DARA arm of the study. Those results are the best ever reported in a phase 3 randomized trial. We always think about patients with high-risk disease. And what about high risk when patients are treated with a quadruplet combination? You see here in yellow, DVTD, DARA arm of the study in standard risk patients. And you have here in green the DVTD DARA arm for high-risk patients. And definitely there is a difference. The arms with daratumumab for patients with standard risk and high risk are definitely better as compared with VTD. But there is a difference when looking at standard risk and high risk for patients treated with DARA. So even with a quadruplet combination, we are not able to overcome the poor prognosis of patients with poor cytogenetics. And, well, this is not good news, to my opinion. So why not looking at VRD instead of VTD plus daratumumab? So VRD and DARA was tested in this important phase 2 Griffin study chaired by Peter Voris from the US. 200 patients were randomized. The study design is very similar to that of Cassiope. VRD or VRD DARA, both before and after stem cell transplantation during consolidation. And again, same story, when looking at the response rate in the DARA arm of the study, that's a phase 2 study, the response rate is increased as compared with VRD alone for VGPR, CR, or better, and you see the results after induction, after stem cell transplantation. The responses are really deepening over time. The PFS and OS are rather premature with a short follow-up, but nevertheless, you can see the estimated PFS in the DARA arm of the study, almost 96% at 2 years, and the results are, to my opinion, outstanding both for PFS and also for OS. But the results are rather good as well in the VRD arm of the study without daratumumab. So definitely a huge improvement in the outcome of patients treated with stem cell transplantation in the area of VRD or VRD plus monoclonal antibody. Those results are really impressive also in the VRD arm, as I mentioned here. Definitely we will know if VRD DARA is better than VRD alone in the phase 3 randomized study Perseus that is closed for enrollment in Europe. We have enrolled more than 600 patients in this prospective comparison of VRD and VRD DARA, both before and after stem cell transplantation. So definitely quadruplet are, to my opinion, the future of induction for stem cell transplantation. But what about KRD, and daratumumab. We have very few data of this quadruplet, and one important set of data came from ASH, last ASH, and Dr. Ola Landgren from Sloan Kettering in New York reported a phase 2 study, a small phase 2 study with weekly Carfil, Lendex, and daratumumab. The number of patients was rather small, 41 patients, and the median follow-up at the time of the study report was also very short, less than 9 months. Ola proposed 8 cycles of KRD Dara weekly Carfil without stem cell transplantation. And he showed that after 8 cycles, the MRD negativity rate, 10 to the minus 5, is very high. Almost 80% of the patients are able to reach MRD negativity without stem cell transplantation with KRD Dara alone. What is also important to consider, although the follow-up is very, very short, is that no MRD negative patients have progressed yet at the time of the report. And again, very high MRD negativity rate assessed by NGS, 10 to the minus 5, and no death on study. So based on this data, Ola Landgren is claiming now that maybe we can postpone stem cell transplantation and use a quadruplet incorporating carfilzomib and daratumumab. These data were also proposed at the last ASH meeting from the MASTER trial reported by Dr. Costa from a US consortium. He looked as well at KRD Dara, 4 cycles of induction, stem cell transplantation, and then consolidation, 4 cycles or 8 cycles were proposed with the same combo. He looked systematically at MRD negativity rates, 10 to the minus 5 by NGS at each step of the strategy, after induction, after stem cell transplantation, after 4 and after 8 cycles of consolidation. And this study is very provocative because when patients were consecutively twice MRD negative, the treatment was stopped, in fact. So this is the first proposal of a risk-adapted MRD-guided strategy. And when you're looking at MRD negativity rates, 10 to the minus 5, after 4 cycles of KRD Dara, 40% of the patients are reaching MRD negativity. After stem cell transplantation, 73%. And when you are adding 4 cycles of KRD Dara consolidation, the MRD negativity rate is very high, above 80%. And the majority of the patients were able to stop the treatment, and at the time of the study report, with a short follow-up, no patient did relapse. So what about maintenance that we are proposing almost systematically for our patients? In fact, LEN maintenance until progression, according to the labeling of the approval, is standard of care. This is based on a meta-analysis reported by Dr. McCarthy in the GCO 3 years ago, and you see that overall survival is highly improved with LEN maintenance versus no maintenance or placebo with a hazard ratio of 0.75. An improvement of 2 years in the overall survival rate with LEN maintenance that we are proposing almost systematically for our patients. You have heard probably about Tourmaline MM3 study comparing ixazomib, the oral proteasome inhibitor, following stem cell transplantation as maintenance versus placebo. The paper was published 1 year ago in the Lancet, and you see that with ixazomib, that is a very safe drug, in fact, provided weekly, the median PFS was improved from 21 months in the placebo arm up to 26 months. So this is, to my opinion, a moderate improvement. We don't have any OS data because the follow-up is too short, but ixazomib could be a drug proposed during the maintenance setting. But we know that proteasome inhibitors are, when combined, to IMiDs synergy. So why not using LEN versus LEN plus IXA? This is the phase 3 study that is currently proposed by the Spanish group after stem cell transplantation. Patients are randomized to receive LEN versus LEN plus ixazomib, and we will know definitely if the combination of 2 agents, ixazomib and LEN, is better than LEN. And in this case, the Spanish colleagues are looking systematically at MRD negativity as well during the maintenance phase. CD38 are also proposed during maintenance, and in the part 2 study of Cassiope, we are looking at no maintenance versus DARA maintenance during 2 years. So the field is changing quickly. LEN maintenance is standard of care, but in the near future, for sure, we will add potentially either CD38 antibodies or ixazomib to LEN. But one important concept, to my opinion, is the concept of sustained MRD negativity. If we want to cure patients, patients have to be MRD negativity at least 10 to the minus 5 during a very long period of time. And for that, we have very, very few data. Some data are coming again from the Forte study in Italy, looking at KRD stem cell transplantation versus KRD alone without stem cell transplantation. And before maintenance, you see that the MRD negativity rate was 58% in the transplant arm of the study versus 54% in the KRD arm alone without stem cell transplantation. So one may say, okay, the results are almost identical in terms of MRD negativity, so maybe we don't need stem cell transplantation anymore, and a combination using carfilzomib is strong enough, in fact, to postpone stem cell transplantation. But our colleagues looked at persistent 1-year MRD negativity rates. And you see that in the transplant arm, after 1 year, we have 90% of the patients that are remaining MRD negative. In the KRD arm alone, without stem cell transplantation, less patients are remaining MRD negative. 78%, I would say only. That's based on small numbers of patients, but this is especially true for patients with high-risk disease. Only 72% of them were remaining MRD negativity in KRD arm versus 90% with high risk in KRD plus stem cell transplantation. So this is also one new argument for systematic stem cell transplantation, but we need more data for sure to explore this very important concept of MRD negativity. So there is here a huge challenge, in fact. Should we propose systematically in the era of a quadruplet combination stem cell transplantation for our patients, yes or no? We don't have any response yet. Maybe potentially the guidelines are going to change in the near future. You see here the potential European guidelines in 2022. For sure, we are going to incorporate CD38 antibodies to VTD or to VRD or to KRD. The maintenance will also change from LEN to LEN plus IXA or LEN plus CD38 antibodies. But to solve the issue of delayed stem cell transplantation, yes or no, in the era of quadruplet combination, we need a randomized study. And this is what we are going to do into the French group. By the end of this year, we are going to enroll patients to receive a quadruplet combination with KRD isatuximab, that is the second-in-class CD38 antibody. And we will propose 6 cycles of this quadruplet, very active combo. And we will evaluate systematically MRD by NGS 10 to the minus 5. And for those patients reaching MRD negativity, the good risk group of patients, we are going again to randomize patients for no stem cell transplantation versus stem cell transplantation. So this study will be able to answer definitely to the question, in the era of a quadruplet combination for good risk patients, is it possible to postpone stem cell transplantation, yes or no? And I thank you for your kind attention.
I'm going to spend the next 20 or so minutes really talking about what are the new drugs that are in development and how do we manage patients who may relapse after all that excellent therapy. And to really give you a sense of how U.S. practice has an impact in terms of outcomes, this is actually an analysis from our center looking at 1,000 patients who all received RVD induction and risk-adapted maintenance. And as you saw so nicely from Philippe, the IFM trial really demonstrated the benefit of lenalidomide maintenance, but that was short-term lenalidomide maintenance. This data here for all patients, standard and high risk, demonstrates the value of continuous lenalidomide maintenance. And one of the things that I'm most excited about from this data set that hopefully you'll see in a manuscript very soon is the fact that we expect the overall survival for the average myeloma patient now to be greater than 10 years. And that is such a dramatic change from where we were 15 or 20 years ago, where the average survival was 2 to 2.5 years. And I think that's a testament to the international collegiality of working together on this problem that we call myeloma. Now, when patients relapse, it's important to understand the patterns of their relapse. And what I think you briefly see here is that a majority of patients relapse in the context of biochemical relapse only, with only about a third having symptomatic relapse. And as you can see, lytic bone disease or anemia tend to be some of the more common reasons why patients will relapse. And as we talk about early therapy for patients with biochemical relapse, this is only going to become more challenging in an era of MRD assessment. Because if somebody goes from 10 to the minus 5 to 10 to the minus 4, that's not only biochemical relapse, that's molecular relapse. And so how do we make decisions on changing treatment or switching therapy, not only for somebody who goes from 0.1 to 0.3, but from somebody who goes to 10 to the minus 5 to 10 to the minus 4? And I will tell you right now, I don't think we have answers on how to manage those questions right now. Now, when we talk about restarting therapy, there are a number of different features that I think are important. And to me, a patient who has biochemical relapse does not immediately get started on salvage therapy. Many of these patients can have a very indolent relapse, and I look for rapid rate of change in the M protein or free lights. I look for whether or not they had high-risk genetics at presentation, and I look for whether or not they presented with renal failure or other complications that could be significantly morbid if we allow biochemical relapse to occur. And if the answer to those questions are no, I may often just watch them every 4 to 8 weeks to get a sense for what their proteins and what their free lights are doing before I begin to intervene. And these are a number of indications and prognostic factors that you can use in your practice to move forward. So when we talk about relapsed myeloma and how to approach it, one of the things that continues to come up, particularly at a meeting like this, is the role of salvage high-dose therapy. And this is data from the British group published by Gordon Cook, looking at salvage second transplant in black versus standard therapy. In their approach, it's cyclophosphamide-based therapy. And as you can see, the PFS clearly favors the use of second transplant. Now, one of the factors that I think is most challenging is if we expect the minimum duration of remission in a patient who gets induction, transplant, and LEN maintenance to be at the minimum 48 months, which is what was demonstrated by the IFM study, then how long is long enough for us to consider a second transplant? And certainly at our center, we would think about 3 to 5 years being the minimum benchmark for a second salvage transplant, with the intent of improving PFS for that given patient. Now, there are a number of patients who may develop cytopenias over the course of the treatment for their disease, and using a second transplant to rejuvenate their bone marrow is, however, something that we do far more frequently than we do a second transplant, given the availability of modern drugs. Now, there are many phase 3 randomized trials that have demonstrated benefit for a triplet over a doublet. And I think that most would be hard-pressed to not agree with the statement that a triplet is better than a doublet in the context of early relapse. And you can see all of these different trials here. And I think one of the challenges is that at least 4 of them used lenalidomide and dexamethasone as the backbone of that control arm. And I think the real challenge for us right now is if patients are progressing on the context of continuous lenalidomide maintenance, do any of those RD control arms really have any value for us in 2020? And my answer to that is no, they don't. I don't think about reusing lenalidomide if a patient is progressing on lenalidomide maintenance. So are there other trials or other potential things we can think about that may be useful and have data, particularly in the phase 3 setting, for us to consider? And the first thing that I'll talk a little bit about is DARA plus POMDEX. And this was data published a few years ago now by Ajay Chari in the phase 1b portion of the study, demonstrating highly active POM-DARA in combination. And again, many of these patients were resistant to DARA or resistant to POM when they came into this. And this was a median of 4 prior lines of therapy. So not necessarily the same situation as the early relapse situation that we're talking about right now, but certainly this this is a very active regimen. And our group has recently published on a small series of patients who received Pom-Dara in first relapse. And the median PFS in this is well over 40 months, suggesting this is a very potent salvage regimen for patients who are progressing on single-agent lenalidomide maintenance. Now, what are some other novel triplets? Well, recently we've seen publication of Elo-Pom-Dex, or Eloquent-3 from Dr. Demopoulos. This again suggests that the triplet of Elo plus Pom-Dex clearly is better than pomalidomide and dexamethasone. This was also a one-line later relapse study, but certainly suggests this can be a very effective regimen. And again, the triplet is better than the doublet. What about using Pom plus bortezomib and dex? We know the patients have relapsed on len maintenance, but bortezomib still remains an option for these patients. And this was the Optimism trial demonstrating PVD is superior to VD in the context of a randomized phase 3 trial with 1 to 3 prior lines of therapy. At ASH this year, we saw very exciting data presented on the Candor trial, which was carfilzomib plus Dara-Dex versus carfilzomib-Dex. And the important thing to remember in this is that this was KD given at 56 milligrams per meter squared on a twice-a-week schedule. And so this, I think, is an important dose to think about because the combination of Dara plus carfilzomib, in theory, is a very potent combination. And this was a 2-to-1 randomization in this early relapse trial. And what we saw was a significant improvement in the triplet over the doublet in terms of progression-free survival, and that was also associated with not only an improvement in overall response rate, but actually an improvement in MRD negativity as measured by 10 to the minus fifth using clonoSEQ. So this, again, triplet combination are drugs that are approved, that we can use, and that clearly will have activity in the context of lenalidomide resistance. And again, if you begin to look at safety, no different than what might expect in a similarly randomized phase 3 trial. Cytopenias were not unreasonable, as well as upper respiratory tract infection and pneumonias, something that I think many of us are getting used to dealing with in an era where we're using a lot of daratumumab, particularly long-term daratumumab, where infection prophylaxis certainly is something to make sure we're paying attention to. Now, the other antibody that is on the block is isatuximab. This is another antibody that targets CD38. It's a different epitope on CD38 than daratumumab. And again, we know it has several different mechanisms of action in terms of how it works. And what we saw from the Icaria trial was Isa-Pom-Dex versus pomalidomide and dexamethasone. Again, very similar to the Eloquent-3 population that I showed you earlier. And the primary endpoint was PFS. And what you see here is 11.5 months versus 6.4 months. Again, significant improvement in PFS favoring the triplet, and this is phase 3 randomized data supporting early CD38 plus Pom-Dex in the context of early relapsed myeloma.
Based on these results, isatuximab was recently approved by the FDA in combination with pomalidomide and dexamethasone for the treatment of adult patients with multiple myeloma who have received at least 2 prior therapies, including lenalidomide and a proteasome inhibitor.
If you look at response summary, again, you can see significant fraction of patients achieved VGPR or better, and certainly some of the MRD data is currently in progress as well. We'll see that in the coming months as well. Now, one of the things that is really quite interesting about this, at least as measured in this trial, was the change in renal function. And as you can see, a significantly higher fraction of patients had improvement in renal function with the addition of isatuximab. And I think that this is something we're seeing not just in myeloma, but in amyloid patients as well, where the addition of CD38 targeted therapy does appear to have an improvement in overall renal function, likely as a consequence of speedy reduction in the M protein and the light chains. So I think these are really important supporting documents to the idea, A, of a triplet, and B, of using an anti-CD38 antibody. Again, if you look at treatment-emergent adverse events, you can see not uncommon for what you'd expect for a CD38 targeted agent here, and again, relatively similar between the 2 arms across the board. Now, what about other antibody-based trials that are in development? This is the IKEMA trial. This is ESA plus CARDEX versus carfilzomib and dexamethasone. This trial is ongoing now, another 38-plus proteasome inhibitor, phase 3 randomized trial, and we wait to see some of this data coming in the near future as well. So in terms of some of the take-home messages with new evidence on antibodies, again, new combinations show triplet with carfilzomib are clearly very active. This is important when we're thinking about a LEN refractory patient and options for patients progressing on LEN maintenance. I think we have several that are either carfilzomib or pomalidomide or CD38 based, depending upon how you want to look at it. And again, the ICARIA trial, I think, gives us evidence for a POM-based phase 3 with an antibody in the early relapse setting as well. Now, what about treating patients with relapsed or refractory myeloma? We know that BCMA is a very important target in myeloma. I think this is probably one of the better targets we have in myeloma because its expression is less ubiquitous than CD38 or even SLAMF7. And so this is certainly very exciting. And there are a number of different targets in development going after CD38. The first one I'm going to talk about is belantamab mafodotin, or Belamaf. This was a randomized phase 2 trial that evaluated 2 different doses of Belamaf. And remember, in the phase 1 trial, at the maximum tolerated dose, the overall response rate was about 60%. Now, if you compare the current treatment algorithm for where we are here, this is a median of 5 to 6 prior lines of therapy. And look at Belamaf in that phase 1 trial, the response rate was somewhere around 40%. So not quite as good in a more heavily relapsed and refractory patient population. This is basically, I won't say an end-stage myeloma patient population, but certainly a heavily relapsed and refractory population as well. And this is the waterfall plot demonstrating the difference between the 2.5 and the 3.4 milligram per kilogram dosing. You can see relatively similar. Overall response rates were actually quite similar between the two. And the most common adverse event we see with Belamaf is corneal toxicity and hematopoietic toxicity. The hematopoietic toxicity is reversible. It's a heme toxicity on target as you deliver the CD38 antibody drug conjugate into the bone marrow. More importantly, the corneal toxicity is on target as well, a consequence of the chemotherapy attached to the antibody, the MMAF. That is reversible in nearly all patients as well. And again, what I think you see here is that many patients can continue to have ongoing responses with this Belamaf antibody drug conjugate as well. Another way to target BCMA is CC269, which is a bispecific antibody that, again, is a humanized IgG1 that is basically a T-cell engager. It brings a T-cell in proximity to the plasma cell and then results in T-cell activation and T-cell killing of the myeloma cell. This is a strategy that I will tell you, personally, I was skeptical would work in myeloma because I was concerned that the T-cell function at this point in a refractory myeloma patient was so poor that you wouldn't be able to engage or activate that T-cell. Fortunately, I was wrong. And this is data presented at ASH from Dr. Costa, where he clearly demonstrated at the higher doses an 89% overall response rate. Again, a very small number of patients, but very encouraging data that validates additional data we saw from AMG 420 before, which was another T-cell engager that had a different mechanism and half-life than 269, again suggesting that this concept of BCA targeting with a T-cell engager, even in refractory myeloma, can be very effective and very potent. And I think we look forward to phase 2 data on this compound as well. Now, I'm going to end the BCMA-directed approaches talking about CAR T cells. And this, I think, is an area that all of us are very excited about in all of hematologic malignancy. And this is data from Dr. Raji's paper that was published in the New England Journal looking at BB2121, which is an anti-BCMA CAR T cell. And I think you all know the schema and the process for making and collecting CAR T cells over time. This is the updated phase 1 results, which demonstrates a median PFS of 11.8 months and very high overall response rates. Now, many people look at this 11.8 months and say, that's not long enough. And many people look at it and say, that's really long. Let me give you some perspective. If you think about the median PFS for CD19-directed CAR T cell in diffuse large B-cell lymphoma, The median PFS is between 3 and 4 months. So this is significantly longer than that. What we don't know about, that we know about in large cell lymphoma, is the tail of that curve. Is there a tail on this curve that gives us a long-term, hopefully, cure fraction that will make it somewhat similar to what we've seen in the lymphoma or ALL world? And that right now, we don't know the answer to. But clearly, you have to get good responses and maintain good responses for this to be effective therapy.
In addition, Rajay and colleagues also reported that the use of BB2121 in relapsed refractory myeloma was safe and tolerable, with most CRS events grade 1 and 2 in nature. A low rate of grade 3 events was also reported by the researchers.
Now at ASH, we also saw data on Cartitude. This is J&J 4528. This is another vector construct that binds 2 different domains on BCMA. This is basically a cousin of the LCAR that we've seen data on from China for a long period of time, and this was a phase 1 trial done in the US, only 29 patients, but 100% overall response rate. And one of the things that differentiates CAR T cells in myeloma from CAR T cells in lymphoma and ALL is the fact that the CRS, severe CRS rates appear to be lower, and that the rates of severe neurotoxicity also appear to be significantly lower in myeloma. And we don't know whether that's a target effect, whether that's a construct effect, or whether it's a disease effect. There's something different about these patients. But certainly, CAR T cells are a lot easier to give in the context of myeloma than other diseases that have been studied to date. So again, if you look at this summary slide, you can see a number of different toxicities that are somewhat unique, but again, different from what we see with other CAR T cell experiences in other hematologic malignancies. And I think that this, again, speaks to the power of this therapy. And the question is, how do we maximize its efficacy? Can we bring it earlier in lines of therapy? And can we do things to increase the tail on that curve of PFS? So again, when we think about take-home messages for targeting BCMA, again, clearly this is part of the future therapy in refractory myeloma. We hope to have at least 2 drugs approved that target BCMA in the next year, one of which will likely be a CAR T cell, one of which will likely be, we hope, an antibody-drug conjugate. Again, these are options for all patients regardless of their performance status. My suspicion is patients will cycle through different modalities targeting BCMA. I hope it's not a one and done and you never get to get the other ones, because I think the others are clearly very effective. And again, they are being moved earlier and earlier into lines of therapy. Now, I'm going to wrap up with just a couple of other new drugs and targets in myeloma that I think are, again, continuing to complicate our decisions on treatment as we go forward. And the first is selinexor, which was approved last year by the FDA in the US, selinexor dex from the STORM trial. And as you can see, if you look at MR or better, roughly 39.3% of patients had an MR or better. One of the challenges of selinexor is the toxicity at the FDA-labeled dose and schedule. And so I think what we're all excited about are the combination trials, whether it's combining with a proteasome inhibitor or an IMiD that allows you to reduce the dose of selinexor and reduce the incidence of severe fatigue and GI toxicity. And many trials are coming down the pike to address this combination approach as we go forward. Iberdomide is another drug that's in early development, and I've reported on this at ASH and ASCO in the last year as well. Iberdomide is another in the immunomodulatory class of drugs. This is called a CELMoD. It's more potent for targeting cereblon and has much more potent immunomodulatory effects than we saw with either thalidomide, lenalidomide, or pomalidomide. And so one of the things that we've noted with iberdomide is that even in a median of 5 prior lines of therapy, we're seeing roughly a 30% overall response rate. The durability of this is currently pending. We don't know the answer to that in a larger patient population. But I think of iberdomide as the son of POM. And the son of POM, I think, is pretty potent. And I think we should all be excited to think about combining iberdomide with some of our other available anti-myeloma drugs as well. I want to also briefly touch on Vanetta Clacks, because I think Vanetta Clacks is a very exciting approach in the context of myeloma. This is the first true precision medicine approach in myeloma. There have been a number of positive and negative data sets that are out there, and one of the things that I want to take a moment to talk about is the update presented at ASH this year on the Bellini trial. This was the initial data on the left that got everybody excited. Big improvement in progression-free survival, but on the right side you see a decrement in overall survival. And this was taking all comers. And so the question was, is Vanetta Clacks doing something that we should be concerned about? Now, what was presented at ASH this year was an updated subset analysis focusing only on the 11-14. And this is clinical responses on the left, MRD assessment on the right, looking at Vanetta Clacks bortezomib dex in green versus bortezomib dex in the blue. And what you see is in the 11-14 subset, huge differences in response rate, huge differences in MRD negativity. And if you look one step further at PFS, huge differences in PFS that did not result in a difference in overall survival favoring the control arm. So this, to me, provides the safety signal we need to say that we're not going to take all comers for Vanetta Clacks in myeloma. We're really going to focus on the 11-14 subset of patients, and in that 11-14, whether you use Vendex or whether you use Ven-bortezomib and Dex, clearly an improvement in response, depth of response, and PFS without a disadvantage in the survival subset overall. So again, when we talk about heavily pretreated myeloma, I think there is a place for Vanetta Clacks in the 11-14 subset. We know that amyloid has a high fraction of 11-14. We know that plasma cell leukemias have a high proportion of 11-14 as well. And so figuring out how to use it in that subset, I think, is really exciting. Selinexor is an option for those with refractory myeloma, likely in combinations, and new IMiDs are on the way. Be ready and stay tuned because, again, they are clearly very active. So we've got some time for Q&A.
Hi, regarding BCMA-targeted therapies, I was just curious if you're aware of any data available for patients who relapsed or had progressive disease after BCMA CAR-T and whether the other BCMA-targeted therapies are still effective. A lot of the trials excluded those patients, but now that we're seeing a lot of these, you know, the tail is looking closer to 20% or so.
Right.
You know, we can't enroll the patients on a lot of those other BCMA-targeted therapies if they failed prior CAR-T, but in the future, I'm wondering if that may be an option.
Yeah, I think almost all the trials now using BCMA-targeted therapy, no matter what modality, are enrolling cohorts of prior BCMA exposure. So we'll have that data on CAR T cells. I think both the T-cell engagers and the Belamaf are actually beginning to enroll CAR T-cell failures as well. So we will have that data likely in the next year, but I agree most of them have excluded any other prior
Yeah, I
BCMA.
mean, the Belamaf, you know, we're looking at trying to get it available as compassionate use.
Right.
Not sure what the efficacy will be in patients who failed BCMA CAR-Ts.
So the one silver lining, if you will, that unlike CD19, loss of BCMA does not appear to be an issue when patients progress on CAR T cells targeting BCMA. So I think it's possible that you could re-respond to a BCMA-targeted approach, and that may be different, again, than what we've seen in lymphoma.
Why in clinical practice, when we practice treatment of myeloma patients, we don't see similar results that is published in the clinical trial? Should we apply the inclusion-exclusion criteria when we practice, which is difficult, or how we can really reach the outstanding outcomes we are seeing published in the clinical trials?
Well, you're right that in the routine practice, in the real life, sometimes we are rather disappointed by the results of new combinations or new agents, in fact. And as you mentioned, potentially that may be related to selection criteria, inclusion and exclusion. We have in clinical trials patients that are more fit as compared with the real life, less patients with renal impairment and so on, or performance status that is impaired in the real life. So you're totally true. But nevertheless, into clinical trials, you are comparing two groups of patients with identical inclusion and exclusion criteria, and if you have a benefit of a new combo or a new agent, this benefit is maybe true also in the real life.
I just have a question on the cost of myeloma care. Looking at this proposition, I see there are, triplets along with monoclonal antibodies, so that will make a quadruple therapy for induction, and looks like potentially a quadruple therapy also for consolidation after transplant, and looks like triplet for maintenance, will amplify the cost of myeloma care. How do you envision that response from patients, authority like FDA and insurance companies overall to respond to this type of intensive approach?
Well, I mean, I think that that's a fair question. And I think one of the questions we have to examine, is about duration of therapy. If we're going to use quadruplets as part of the induction therapy, is the old or the recent mantra of treatment until progression really makes sense? And in my view, the answer is probably not likely. We're probably going to have to cut back somewhere. The second is, just because you use a quad up front doesn't mean you're going to use a quad in consolidation or maintenance. And so I think, the Cassiopeia study is an interesting way to look at it, because I agree that induction of quad makes sense. I'm not convinced that consolidation and maintenance makes sense yet. So in our algorithm that I mentioned, we're using RVD plus DARA. We're only doing that for the first 4 cycles. And then we switch to our standard algorithm for maintenance, which is risk adapted overall. So I think those are things that we're going to have to demonstrate clear benefit before you can make a recommendation for quads across the board.
I agree with of course, with the Sakharinen point of view. And if I may, if you look the last slide of my talk with the future IFM study, we are proposing a fixed duration for those patients with a good risk, MRD negative after induction. We are going to stop the treatment and the duration of maintenance, because we are thinking that in the comparison of arm A versus arm B that you can see on the screen, we are going to cure half of the patients. So the goal is to cure, and the definition of cure is to be without any treatment.
Yeah, no, I think that that's a really important point. And how we use MRD, I think, is certainly there's up for a lot of debate and discussion. But I think those are the kinds of strategies we need to think about. We appreciate your attention and hope you learned some valuable information during this session. Thank you.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/JHF860. This activity is supported by educational grants from Adaptive Biotechnologies, Amgen, Celgene Corporation, Janssen Biotech Incorporated, administered by Janssen Scientific Affairs LLC, Takeda Oncology, and Sanofi Genzyme. This activity has been jointly provided by the Medical College of Wisconsin and PVI, Peer Review Institute for Medical Education.